And we are recording. Hello, Dr. Court. Thank you so much for being here today.
Oh, thank you for having me.
Of course. So what we'll do is we'll start with I'll have you give a brief overview of kind of your path to your current career, anything in your education that you want to discuss, and then we'll get into student questions.
Okay, sure.
Cool. Perfect.
Maybe I can start off just where I went to college.
Yeah, perfect.
Okay, so I attended UC Berkeley, which was my first choice to go to, and I was so happy to get in. And I entered as a major in molecular and cell biology.
Wow.
And, with an emphasis in neuroscience. And that's what I studied when I was there. And during college, I got got more interested in chemistry and physical chemistry. And I had ideas about what I wanted to do for research projects, because I originally thought I was going to be a researcher.
Wow.
And so I applied for some grants, and I got some grants to work in labs because I didn't have the finances to sponsor myself without getting paid, so it was either work as a waitress or get a grant to do research. So I got a grant and worked in a lab. Mm-hmm. And my first experience in the lab was a difficult one, and I was thinking about that this morning. The doctorate student that I was working underneath had told me that maybe it would be good if I went to go work in something that Latinos know very well, like social services. And so that was my first experience. Here I am with this money, excited to do my project, and I was told that I needed to go work in social services, something that Latinos were good at.
That's insane.
And I was very young. I was 18, and so I was so upset, and that made me even more determined. And then I reapplied to another lab, and that was a super fruitful 3 years. And I did lots of great work, and I worked with a great group of people. And I loved bench science.
And so what is that?
Bench science is basically doing, chemistry reactions, Western blots, basically working with Petri dishes and cell lines. But when I ended Berkeley, I thought, I don't know, there was something missing. Like, I liked science and I liked working in the lab, but I also liked working with people, and I like working in social justice issues. And after I graduated college, I went and did a lot of community work for a couple years. And I was like, what am I going to do with my life? Like, I really like community work. I really like working. I was working in the jails. I was doing a lot of health education. I was working in lots of juvenile hall work.
So cool.
So I didn't know, what am I going to do with my passion for working with underserved and social justice issues? I love science, and I love human behavior and anthropology. And finally I said, you know what, I'm just going to go to med school. And so I went to medical school at UCSF.
Very cool.
And eventually graduated, and here I am, right?
That is so cool. So how much time in between your undergrad and then going to med school did you spend? If that made sense.
But between undergrad and med school, how much time did I take off? I think I took off 3 or 4 years.
Okay.
I'm so happy I did that, because I worked, and I would save money. I didn't have a lot of expenses. It was just me, and I didn't live, in a lavish lifestyle. And then I used my money and I traveled. So I traveled all over the world
That's so
for a month, and then I'd come back and work, and then I'd travel. And I'm really glad I did that, because you don't always have that opportunity to do that in life, to take off for like a month or 6 weeks to travel. And, so that was good. So yeah, I took about 3 to 4 years off before I decided to go to med school.
Wow, that's really awesome. Do you think, what was the process of like applying and getting into med school?
We have to take a lot of tests. So that's being I'm a doctor. There's like all these tests that you constantly have to. I think it was the MCAT.
Yeah.
The MCAT, and so I studied for the MCAT, and then that was mainly it. I had already taken all my science courses, so I didn't really have anything to do. So I just had to take my MCAT. That was it. And I think I visited some schools, maybe, I don't remember. I think I visited some schools before applying, and got into the schools that I had wanted to go to. So it wasn't too difficult of a process, I mean, in terms of deciding where to go.
Yeah, that's so cool. And then where was I going? Shoot.
Well, I got into med school, and then med school is like 2 years of schooling where we do just basic, the body, the lungs, the kidneys, the brain.
Yeah.
And then your last 2 years of med school are clerkships. So basically you are in the hospital, in the ICU, working in tandem with residents and professors, physicians, trying to figure out what you ultimately want to study.
Yeah.
So some of that is required, like there are some required clerkships, like we all have to do surgeries, we all have to deliver a certain amount of babies, we all have to do neurology, and then it's sprinkled in there. By the time you get to your last year, you choose what extra clerkships you want to do depending on what kind of medicine you want to do.
Okay. And did you know you wanted to go into psychiatry when you entered med school?
No, but one of the things is that one of the criteria for me, one of the reasons why I wanted to go to UCSF is because Dr. Bruce Miller worked there. Oh. He was a neurologist, a brain behaviorist who did a lot of work that I thought was very interesting. And so I had Bruce Miller at UCSF. I had a couple of folks at Yale that I wanted to work with, and a couple of folks at Harvard. There was a couple of folks sprinkled. And so when I was picking schools, I was really trying to figure out, where would they let me do the kind of research I wanted to do. And so Bruce Miller does a lot of brain behavior. And so when I decided to go to UCSF, I got into his lab pretty quickly, also with the grant, and was able to carry out research. So during that time, I got really interested in behavior.
Yeah.
But, I'll tell you the truth, Callie, like I was kind of a mixed bag because I really liked neuroscience and I really liked behavior. Mm-hmm. But I didn't think that I wanted to be just a bread and butter neurologist.
Yeah.
And then I did my clerkships and I thought I really liked surgery. I really liked OBGYN. I liked doing fetal maternal medicine and fetal surgeries. And I was actually quite good at it. I don't know why, but I was good at surgeries. And I said, this is great. So I'm going to become a high-risk obstetrician. So wow. I was like, combine this with neurology and obstetrician. And then all of a sudden, randomly, I took a clerkship in child psychiatry and I fell in love. I was like, this is what I want to do. And that was a big decision to give up research in neurology, high-risk obstetrics, mm-hmm. and go into psychiatry. That was like, everybody was like, what? But it was really those clerkships that I was like, oh yeah, this is what I want to do. And, you know, when I think about it, when I was, well, how old was I? I was in my 20s, mid 20s. I realized, like, you know, over the next 40, 50 years, 60 years that I have on this planet, what do I constantly want to be learning about? Like when I go to, you know, because as a doctor, you have to constantly go to conferences and meetings and take tests.
Yeah, because you need to be up to date with the most recent kind of medical procedures, which are constantly changing.
Right? And so what do I want to listen to for hours and read about? And I was like, the brain.
The brain.
And behavior. So that's why I ultimately went into psychiatry. And psychiatry is great, you know, because like, it's kind of like, you're an anthropologist too, right? Because you're studying people and groups of people, and you want to work in, you basically can go anywhere and do anything, because behavior is everywhere, you know?
Yeah.
So, it was a big decision, but I'm glad I did that clerkship my last year. I just kind of did it, let me check it out, and I fell in love.
That's so cool. And is a clerkship similar to residency, kind of?
So after you finish clerkships,
Mm-hmm.
and you pass all the tests that you have to take, you get your license.
Okay.
Once you have your license, then you can apply for residency. And residency is what you do for, depends, probably like in general 4 years.
Okay.
That's where you accumulate your hours to become competent in your field. And that's all you do in residency, is what your field is.
Okay.
80, 90, 100 hours a week for 4 years. That's residency.
Yeah.
After residency, if you decide to specialize further, you do a fellowship.
Okay.
So I did psychiatry and neurology, adult psychiatry, neurology, finished that, and then I did a fellowship in pediatric and adolescent psychiatry.
That's awesome. Wow.
If you're done with that, then you can, if you decide to, which I recommend everyone doing, you take your boards and you become boarded in those fields.
Okay.
And now you're even more of an expert. Does that make sense? So it's
you get a licensure after 4 years,
right.
But then you do your residency and fellowship, and you get board certified after so a total of about 8 years in med school, or not med school, but
4 years. Residency is 4 years. Like maybe at the minimum 8 years.
Mm-hmm.
But it's so much fun.
Yeah, if you love what you're doing, it's not going to be
I know it sounds like a long time, but it's like you're constantly learning, and you're at the next level, and you're like at the next level, and then you're like, your responsibility changes. And I mean, residency was definitely brutal, and fellowship brutal, but it's temporary. It's not forever.
Yeah.
Hours are not forever.
Yeah, absolutely. Where was my follow-up question on that? So do you feel, so when, I know when you go into a PhD program, you do apply to work directly under someone. So that's similar for med school as well. And you're expected to do kind of research, or no? Okay.
No. I actually added an extra year to my medical school and took a year off in med school.
Okay.
Did like a advanced degree in biomedical science and math. So working with Bruce Miller. It's
okay.
Like I just wanted a whole year to do just to not worry about my clerkships and patient care, and just work on my thesis research. But it's not necessary. I just did it because that's something I really liked.
Yeah.
And you know, interestingly, like right at that time when I started working as a researcher, I found out I was pregnant.
Oh, wow.
So, and I wasn't married.
Oh.
Wasn't with, or your boyfriend,
Yeah.
So that was hard to say, oh my goodness, I'm in med school pregnant. And luckily, I had started my research year. And so clerkships are hard to do. I mean, clerkships are hard on the body because you're basically a peon and so basically it was nice because I was able to do a year of research and be pregnant and completely kill myself physically. And I had a really supportive program. And it turned out to be okay. Turned out to be fine.
That's awesome. And do you think that like your background in research has like helped you currently as far as your current work?
I mean, I think for sure. I mean, for starters, like I'm constantly reading articles, and so I can quickly tell if an article has used methods. And
yeah,
once you're an independent doctor, you have to decide how you're going to practice, and there's all kinds of new information coming out, whether through research or on Google, and you got to know, is it something, do I implement this in my practice? Do I change my practice? And so research articles can say, yes, we found that this drug helps or this, but it's like the article, you got to know quickly, did they really go out and set what they needed to do? I think also there's a way that research teaches you to think about things. It's very critical.
Yeah.
Hypothesis, even in therapy, you're developing a hypothesis, you're collecting data based on what people tell you, you're seeing if that data fits. There's just a way of thinking that I think has been really helpful.
Yeah, I think one of the things I kind of stress in this class specifically is like, even if you're not interested in research, you need to be a good consumer of research. So like, say you're treating someone with schizophrenia and all you know is cognitive behavioral therapy, well, that's not going to help someone with schizophrenia, right? Like, you have to understand what treatments are being tested and are working with that population.
Right. Yeah, definitely. I agree with you in that. And to be honest, like one of the great things about being a physician and being a psychiatry is the brain is like, no, I think you could think it's in all parts of medicine, but I'm constantly reading.
Yeah.
Constantly having to learn. And if you can't, I think I already said this, it doesn't require repeating, but you really got to incorporate information quickly, digest it, and see if it's worth sharing with patients or not. Is it worth changing things or not?
Yeah, absolutely. And kind of on that, along those lines, not totally related, but so I watched a really interesting TED Talk, and it was talking about how psychiatrists are one of the only medical doctors that don't look at the organ they treat. And I kind of wanted to just hear what your thoughts were on that and opinion. And
psychiatry is, we still have a long way to go. This is why one of the things that was difficult for me, because when I was doing neurology and behavior neurology, all we would do are brain scans, MRIs, PET scans. So it was very interesting, Callie, because like I had the MRI brain scan, I had the patient that I was doing neuropsychological testing on. And regrettably, the patients I was seeing had frontotemporal dementia, so they would pass quickly.
Yeah.
I would look at their brain. So I had the patient in the MRI scanner, I had the patient in front of me, and then I had their cadaver in their brain.
Wow.
Take a look at what's happening, and then I would be able to look at holistically what was happening. And so actually people don't journal and die, and you don't look at their cadaver brain. Yeah. We don't have scans that we regularly use. And I think the frontier in psychiatry is to be able to get a thumbprint from people, like be able to put them in a scan and run their DNA and come up with an idea of, okay, this is the type of therapy, or this is the type of diet, or this is the type of exercise program this particular brain needs.
Yeah.
We just don't, we're there's a lot of research out there about brain scans, but nothing has met like, okay, this is something that we can regularly incorporate in our clinical use. So yeah, so I agree with you.
Yeah.
I agree with you.
And is that like, have you heard of RDoC?
No, tell me about that.
So
RDoC?
It's capital R, capital D, little O, and then big C. I don't know why. But it's like the research criterion domain where they're trying to take, where they're basically trying to kind of, from my understanding, replace the DSM to include like brain function, valence systems, circuitry, and all that, which would be really interesting. Because part of that TED Talk too was saying that there was this little boy who actually had a frontal lobe tumor, and they were treating him for ADHD. Well, ADHD medication is not going to decrease tumor size. So once they finally did get a brain scan of them and they removed the tumor, the boy's symptoms were gone, right? So it's like, it seems like it would be a very important aspect of treatment.
So yeah, so you're talking about research domain criteria.
Yeah.
And so that's basically been the whole thing in the last several years, the last over a decade now, in terms of circuits and looking at what circuits, and definitely. And I think also as a good doctor or a good psychiatrist, you know, when you spend time with a patient, you've got to know, like, are there any other symptoms, any other physical symptoms? You know, it's not just like structural parts of the brain, but also like rashes, fevers. You know, you've got to really carefully, because you know, you've got to really take a good history and a good physical exam, and you've got to know what you're looking for and what you're seeing, so that you know, does this person need a brain scan? Does this person need this kind of labs? Do they need to do this? Do they need to do that? And regrettably, the way our healthcare system is nowadays is that we're asking primary care doctors, psychiatrists included, to go as fast as possible, meaning to see as many patients as possible, to spend as little time as possible. And so when you're spending little time, time is what you need to figure out what's going on with patients. So, but you know, we continue to vote for a system that doesn't really allow primary care doctors to spend time with patients to really see what's going on.
Yeah, unfortunately, it's definitely a business and disguised as healthcare.
Yeah. Yeah, definitely.
Yeah. Let's see, where was I going with that? Okay. So now to get kind of into some student questions. A lot of students were interested, and you kind of touched on this earlier, in kind of your background being Latina, and kind of coming into this field, not only in like getting the education part, but also like the treatment, because there is this stigma in Hispanic cultures, right, of mental health and like going to see someone. Is that something you kind of worked on in your field or saw, or?
Oh yeah. And I think it transcends Latinos. I think it's for a lot of folks, but you know, even I worked for many years in Southeast San Diego, which is predominantly African American, and I worked in San Isidro and Linda Vista, lots of different, you know, Filipino, Asian, and there is a lot of stigma around. And I think it's really important, if you're working with clients or working with patients, to be nice, be friendly, and it's a really sacred space for people to open up to you. So have that in your mind, that it's a real honor and privilege, and you're getting allowed into spaces that people don't allow other people into. And second of all, to really communicate to people that they're completely in control, in the sense that if they just want to come in and talk, or if they want to find out about medications or find out about their symptoms, and then they want to just think about it, and they're completely in control of what's happening, so they don't feel like you're trying to impose something on them.
Right.
So I think that's really important. I think it's also really important to, it goes a long way to let people know, you know, I don't walk in your shoes, but I'm totally open to hearing what
Mm-hmm.
it's like for you.
Absolutely.
Not just for mental health, but it's also true if you belong to a different culture, a different race, a different SES, different socioeconomic.
Yeah.
Just like, you know, you're right. I don't walk in because, you know, some patients are like, you don't know what it's like, Dr. Corridor. And it's like, you're right. But I'm totally open to hearing that. And people can feel safe and know that you're not judging them and that they're in control and it's okay. Like they can decide what to do or what not to do and etc.
Absolutely. And so to kind of staying on that line, do you feel like being able to speak multiple languages and being bicultural has like given you advantages for the most part?
Yeah. Wasn't when I was younger, but
Right.
now it is. I feel like, well, number one, I think it helps that, you know, whether here or there, and again, this could land, people could say the exact opposite. But when I speak Spanish, I don't have an accent. And when I speak English, I don't have an accent. And English is not my first language. And
Yeah.
nobody could tell that. Number two, I feel like I do, for example, write, I mean, it has been a huge thing for me to be a woman and be Latina and speak Spanish and to treat folks in Chula Vista and San Isidro who've never seen a
Yeah.
Hispanic mental health person and to be able to talk in their own language. And not only that, it's not just language. There's like there's a lot, there's language, and then there's like the way people say things, and when they say it, you only capture it if you've grown up in that culture, you know? So sometimes you pick up on certain attitudes just by the way they said something. I think that's been really helpful. And now, for example, well, the last 3 years, I went into private practice, but I also do, I did for many years, saw migrant farm workers, and all of them were Hispanic. And that was a big passion of mine, is to be able, you know, I do like 8 hours a week of seeing migrant farm workers um, and helping them. So I feel like it has been really helpful for me to speak Spanish and to be bicultural, right?
Yeah.
Traveled around the world. I think traveling has helped me because you can share little tidbits about yourself and understand things just
Yeah.
because you're there and seen that and experienced it, and you're more open to it. So that's really helped as well.
Absolutely. Did you ever study abroad?
No,
College? No? Okay. Would you recommend people try to do something like that? Or is it just like you can kind of go anytime? Well, not anytime, but.
yeah, I mean, I think it just, you know, I think it just depends what people want to get out of it. You know, I didn't travel abroad. I don't remember exactly why. I think I was just so into my research in college that I felt like traveling abroad away from my work. Plus, I did a lot of fun stuff during, you know, I still traveled.
Yeah.
I think it just depends. And, you know, we also traveled to Chile, where my family is. So, I mean, I already got a lot of travel abroad. And then after I graduated college, I worked and saved money. And then I would go on my own travels
So
and do like volunteer work or go do something in another country for a little bit and then come back. And I don't know. I think
that's awesome. And then kind of skipping around, sorry. How does medical school offer stipends or anything? Or yeah.
oh yeah. So I got some grants
Okay.
independent of me, grants related to academics, whatever. And I also got financial aid.
Okay.
It was all financial. I mean, if you're lucky enough to have parents who are paying for it, okay, great. But that wasn't my reality.
Right. And so I know this is like a faux pas. You're not supposed to talk about money stuff, but did that leave you with a lot of debt afterwards? Because I know like for PhDs, right, they fully support you because you're doing research essentially, or not fully, but give you enough to live on. When you go through like financial aid or grants, is that kind of you're getting that stipend through that, or do you kind of accumulate this debt, if that makes sense?
I would say a good portion. I don't know enough about it to speak with a lot of, expertise, but I could tell you that a good portion of people, if you did not have your parents help you, or if you did not have a type of back, a lot of people come from parents who could theoretically pay, but the parents aren't going to pay. They're like, you're in your 20s, you take care of your own
Right.
stuff. So that's a predicament for a lot of students. It's like, what do you do because you have to, even if your parents say you're on your own, you've been on your own for the last 4 years, we're not involved, you still have to show their financial records.
Oh.
Show their financial records. I think it might have changed. I mean, this was like 15
Yeah.
years ago. So you show their financial records, but you're like, I'm not getting any help. So I think a good portion of folks do come out with debt.
Yeah.
And a couple things. One of the reasons why I like medicine and one of the reasons why I like child psychiatry is because I make good money.
Yeah.
And I'm not a surgeon, I'm not a specialist, so I don't make a ton of money, but I make good money. And that was very important to me.
Yeah.
Career. And lots of people discourage people to think about that or to talk about that. But for me, it was very important. I grew up in a family where pretty much all the women relied 100% on men.
Mm-hmm.
And sometimes that wasn't helpful.
Yeah.
And they were not educated, and they were not, that kind of reliance on someone else was not something that I was willing to do.
Yeah.
That I had the money to do what I wanted to do and have the family that I wanted to have and be able to make my own choices. So money was very important. And so my career has been very good in that sense. And I also worked for King Chavez, which is a federally health qualified clinic that was set up under Obamacare, and they paid off a lot of my debts. I worked there, and they paid off a good portion of my medical school debt.
That's awesome.
So yes to debt, yes, but I've also been pretty prudent about how I spend my money. I'm not like, a lot of doctors want to spend, get a new house, and those are all very important, but I was very prudent in how I paid off debt quickly.
That's good. Yeah, my brother-in-law has bought a wooden sailboat. He's an ER doc. He bought, he's buying all these vintage things in Sicily that I'm like, you're really going to bring that? What are you doing? Anyways, that's not here or there. But I definitely see that.
You got to be careful with that, right? And then, I was also a mom.
Yeah.
Right? And I also had this idea, there was never in my head that I had money coming in. So I don't come from a family where they're going to give me a payment on a house, or come into money once certain people in my family pass away. I never tracked that. So I was like, I got to prepare for my retirement. I got to prepare for my child. I got to prepare for catastrophe to happen. And so I always had that, I'm on my own.
Yeah.
So I think that helped. The other thing that's great about psychiatry is that I have a terrific lifestyle.
That is good.
That was very difficult. For example, in high-risk obstetrics, I'm sure it was wonderful, but I didn't see the high-risk obstetricians have a great lifestyle.
Yeah.
They're public, they listen to this, they could argue what they want, but that just was my experience.
Yeah.
I like to play sports. I have a lot of hobbies. I love my family, and I need to have time to enjoy my life.
Absolutely.
And I'm a mom. I really like being a mom, and raising kids requires a lot of time. Doing it well requires time and energy. And if I have a career where I'm getting all my energy and my time sucked, I'm not going to be the kind of mom I want to be.
Right. You need that balance kind of, and not to be just completely drained anytime you get time off.
Yeah. So I often ask myself, would I do it again? Totally.
That's awesome.
Right? That's a good thing to say. Would I do it? I would do it again.
That's awesome. And then like just to kind of also dig deeper and so you said after your residency in child psychiatry, you knew that that's what you wanted. So what about that was like just so appealing and fulfilling, I guess?
Um, it's really a little bit, you never know what you're going to get.
Sorry.
It's very exciting.
Uh-huh.
A lot of patients in the room and you're talking about behavior, you never know what's going to happen.
Yeah.
And I like being bored.
Yeah.
I have a tendency to get bored. And so I like, you know, people bring in human behavior is like not boring at all.
Yeah.
You got to know, and there's so many tools you can use. Like, do you give support? Do you confront? Do you do a medication? Do you tell dad that he's got to stop drinking? Do you pull back? Do you talk to, you know, someone's cutting, someone's hearing voices? I feel like enter the room, there was, and also like, I love working with families. I feel like when you work with families and attachment, you really do a lot of good work. And I also really like teens and kids. You know, I just really like it. And so I feel like in many ways I could do science and I could help people, but I was also an anthropologist. I got to like see people, study people, learn about social groups, all kinds of subgroups of people. Sub meaning like, you know, these are the groups we see, but there's so many other groups in between those groups, and get to learn about that and the mentality and what unifies us as a human race. And, you know, I'm kind of a philosopher too, so I just brought it all together for me.
That is so cool. I love that. And kind of like, to now move into more of like what a day in your career kind of looks like, because I'm sure like no day is the same, no patient or family is the same. So can you explain a little bit about your background in individual psychodynamic psychotherapy and how you use it in your current position?
Yes. So, you know, one of the things about psychiatry is that in residency, you can tailor what you want to do. So you have to take, let's say I did lots of internal medicine, I did neurology, but I also picked supervisors who did a type of therapy and that I wanted to learn more about. And so through their supervision, I was able to see cases and videotape myself and show them and work on a type of therapy. And they would give me readings and tell me what conferences to go to. So basically I tailored myself to learn more about certain theories, certain ways of practicing. And it was a diligent study. It wasn't just, oh, I'm going to dip my feet in it. I mean, it was like, I'm seeing patients, right? So it was a diligent study. And so I use psychodynamic psychotherapy a lot because there's a lot of defense mechanisms, a lot of resistance. And people have their defense mechanisms and resistance. I don't know how much you or your students are learning about that, but that's a major issue that causes human suffering.
Right. Absolutely. People put up walls because of whatever, like those walls are going to keep you isolated, right?
And defense mechanisms come in all flavors, right? It could be could be eating disorder, could be drinking, could be popping Xanax, could be, there's a lot of people do all kinds of things to avoid feeling.
Absolutely.
So you've got to have a basis on knowing how to work with those defense mechanisms and helping people get more in contact with their feelings.
Yeah.
Any other approach does it, unlike psychodynamic psychotherapy. So that's how I use it.
That is so cool. And how is that kind of different from the traditional like cognitive behavioral approach, or is it that different?
It's the traditional CBT approach is much more, the traditional kind is much more, straightforward, I think, much more regimented. But I do think that if you incorporate you can incorporate both theories into your practice, meaning that that the ways that you think or your behaviors are certain defense mechanisms. What are they blocking? Can we change it? Can we, you know, you can, those two actually are not as separate as we think they are. Cognitive behavioral therapy is saying, well, you know, if my thinking pattern, there is something askew with my thinking pattern, right? So I have to realize that. And in psychodynamic therapy, that is also similar, right? And there's something askew with the way I'm doing things. I'm avoiding things. I'm creating defenses against it and resistance. And so those two can be melded. Like, and also you always have to work from a base of attachment, I think, in terms of people.
That's going to be my next question.
Yeah, you have to understand that attachment is the foundation for the human brain. It is more important than anything. I mean, you know, after the World War I and World War II, there were tons of children left in orphanages who had food and water and a bed to sleep in, but they literally died because of attachment, right? And we've seen that over and over again, right? So attachment is the primary organizing part of the brain. So I think that work in forming, you know, I don't want to keep throwing the word around, but if you form a good relationship with the patient and know that they're esteemed in an authentic way. I mean, I esteem all my patients. I think, you know, I'm very fortunate that way. I'm able to really connect, and I find everybody has got wonderful qualities about them. So if you're able to have people feel safe and secure, and then you start talking to them about their attachment when they were growing up and how that has led to certain behaviors and certain ways of thinking, and how do we help them repair those attachment circuits, right, from both a behavioral standpoint and an emotional standpoint. So I think that that's the framework that I work in, is that I really feel like how we attach and who we attach to and what we learned about it really informs how we behave.
Absolutely. I 100% agree. Like, I always in my Psych 101 classes will talk about, so I had two friends, and I'll never show them this video, but one was avoidant attachment and the other one's insecure anxious attachment. And so obviously those two had a very explosive relationship. And it really, like, when you do put it into context, it makes sense. I don't know. I love that theory and model.
You know, and it's interesting because yesterday I worked with a couple in their 30s where the fiance is ambivalent attachment and she is attachment, and they are just beginning to learn about attachment styles. So when I was telling them, hey, this is what I think you are, and they were just like, you know, wow, so many things made sense for them. But I think it really helps people create a framework, like when you're getting anxious or you're getting activated, or hey, when you avoid closeness, this is what's happening, right?
Yeah.
A framework for how to understand themselves and their partner is really helpful.
Yeah, I totally agree. And then kind of like, yeah, so segueing into that, what does it look like, kind of the differences in treating kids and your approach to treating adolescents, to adults and couples, and
to be honest with you, not much. Also, I also follow people's lead. Just like children and teens, sometimes people don't want to talk. Some people are resistant. Some people are looking for me to organize themselves. Some people want, you know, just, I think, reading the room and figuring out what the person wants or needs. Now, and I think that goes for everyone, right? Like a child with a parent talking about attachment, a husband and wife, right? I mean, I'm having conversations with like parents who are in their hundreds and the kids are in their 80s. And we're trying to end of life issues with attachment. Like, why, how do we help people age and die with a sense of dignity, and that they were loved, or if they did not love, why did they not love the way they could have loved? And is there forgiveness in that? And that's all.
Yeah.
It depends also on developmental life cycle, how I bring it up, right?
Yeah, absolutely.
I could be more specific, Cassie.
No, that's great. Thank you. And also, so what are some techniques, because I know we've kind of talked about it, like when you're, especially now, trying to kind of treat younger children, right? I know you said you do play therapy and that kind of stuff. What does that look like?
Depends on the child.
Yes.
So play therapy really depends on the child. Some children, I have to do a lot of initiation and then I just let them take off.
Mm-hmm.
And depending on what they're doing in their room and what's going on with their life, I try to incorporate some skill that we're doing, but I can't be too obvious because I don't think that doesn't make it very fun. And sometimes I am more obvious, like, hey, we gotta learn how to be angry without hitting. You know, what do we gotta do? And, you know, we'll dress up and I have a doll house and we have lots of games and painting, and I really follow the child's lead, and children are unbelievable. They tell you stories, and whether it's they'll tell you stories through their games, through their Legos. And if it's not a story, you're picking up on the emotion, right? What's happening, if they're scared or fearful or happy. And then how do you have them make sense of it, right? And it depends. If they're 3, it's different than if they're 8, and it's different if they're a little bit older.
Yeah. And a lot of that's really helpful, right? Because a lot of children kind of lack the language to be able to say, this is what I feel, or this is why I feel, right? So through something they're comfortable with, they can kind of demonstrate that a little better than, like, you know, as an adult, you're like, well, why do you think that you feel that way? And, you know, the kid's like, what?
You can't, like, I have a lot of kids who express a lot of sexual trauma through dolls, through a lot of doll play. And they're not showing it directly, but there's a lot of situations that the dolls get into where you're like, what do you mean the little boy walked in to this woman and man doing it? But I mean, the little boy's only 5, and the little boy will have little reactions, and then he'll go off to do something else. And so they tell you what's happened in their life that way, without having to directly ask them about it. And you have to go very slow and very gently, make them feel safe and that it's okay, you know. And when people feel heard, and when people feel heard and they feel like they're safe and that someone is attaching to them, all nervous systems calm down. And when nervous systems calm down, they're able to be curious about the world, take in new information. If a child or a human being doesn't feel that way, you can try to teach them every skill you want.
Yeah.
But
absolutely. So true. And I kind of want to now to, like, sorry, I'm like all over the place today. My brain has been fried from this week. But so there's that huge kind of myth that I'm sure you've heard that, like, psychiatrists just push meds. And that's like the main purpose of seeing a psychiatrist. So what are your thoughts on that? How do you, like, do you have patients that just assume that that's what it is? And
it's hard to do that because that, you know, unfortunately, medicine in the last 30 years has been taken away from doctors, and doctors have relinquished it. So there's been companies and bureaucrats who've taken over, and they're trying to make as much money as possible. And when they make as much money as possible, doctors are basically shoved to be as fast as you can. And so doctors then become, okay, psychiatrists are like 15 minutes, see a patient, give them meds. And if they need therapy, but that's not something that med school teaches you. Medical school teaches you to treat patients holistically. But then when you leave, the system has really changed. Psychiatrists used to be really good at therapy, and we used to learn a lot of therapy. But that's just not what the insurance decides the insurances have made those decisions. People who have no concept of medicine or psychiatry have made those decisions.
Yeah.
I don't know how to communicate that. I mean, I have a website, and in my website, I try to make it, friendly, that it's not just medications that I use, but I do believe in medications. Medications have been life-changing.
Mm-hmm.
Whether it's insomnia or OCD or panic attacks or bipolar or psychosis or drug addiction, alcoholism, medications have been very helpful. So I don't poo-poo them, but it's hard to know when to prescribe and what to prescribe. And if you don't know what's going on with people, especially little kids, right? Little kids can look like they have ADHD, but they may be anxious, they may be traumatized, they may be bullied. They may have a learning disability. They don't understand math, and no one's picking up on that. They may have a medical problem. So you got to spend time doing that.
Absolutely. I mean, that was part of something in my thesis that we looked at, so a kid who is witness to domestic violence may then go on the playground and be a bully to other kids. And people label that as just bad behavior. That's a bad kid. But that's part of like the re-experiencing symptoms of PTSD when you don't have the language to say, this is why I'm acting out this way, right? And it's important to be able to kind of see that, get to know that person, see them in different contexts before you can just say, oh, you're depressed, or like whatever it is.
Right. Or like, we need to implement a behavioral program for this bully. And it's like, well, the intervention doesn't match the theory or the hypothesis, which is it is acting out because he's experiencing some scary or overwhelming things at home.
Exactly.
Right?
Yeah. Do you have like strategies for that? Like, do you feel like you're less confined to like just trying to get medication in a private practice than maybe previous physicians? Or
in my private practice, I do what I think is right.
Yeah.
I do how I was trained, which is why I have a private practice. And when I say private, meaning like I don't accept medical insurance. That doesn't mean other doctors might accept medical insurance, but I don't. Which unfortunately lets, really, I end up working with only a certain portion of the population who can afford to come see me.
Yeah.
And this is why I end up doing some extra telemedicine work. But even then, through the telemedicine work, through the migrant farm workers, they really want me to see people as fast as possible. And
yeah,
at least I try, even in those short minutes, I try to have people I try to really make them feel heard and understood. And even though this is a short appointment, I get what you're doing, let's try this. But I'm limited. There is a difference between the job that you have versus the job you think you have.
Yes. Right? Yeah, absolutely.
It's a big thing for doctors, right? They're constantly having meetings about this that patients have no idea about, that administrators are telling you you have a job, and doctors are saying, no, but this is the job I think I have. And they're saying, nope, your job is not to do how you were trained. I can't believe this in a public forum, but this is basically what it is. And doctors won't talk about it because there's a lot of shame in that.
Yeah.
But then, people get pissed off at doctors that the doctor didn't email me back, or the doctor didn't do this, or he only spent like 10 minutes with me. He doesn't even know what he's talking. It's like they have no idea that it's not the doctor. It's the higher up who are telling you that's not the job you have. The job you have is to see people quickly. So please do it, or you can go somewhere else to find it.
Yeah, absolutely. And that's been one of the huge things with Kaiser recently, right? Like they have overloaded their psychiatrists to caseloads of 200. So patients can only see their psychiatrist maybe once a year. And that's really not helpful when you have a psychiatric population you need to see.
People have negative reactions to meds, or people have crises, but
people not consistently on their meds, especially kids that aren't having any oversight, which can be really dangerous.
Yeah.
Absolutely. Yeah, it is. It's crazy. So kind of again, like moving forward, what's kind of the most fulfilling aspect of your job? What's maybe your least favorite? And kind of how do you avoid burnout? And we kind of already touched on that a few parts, but.
Well, favorite aspect, I don't really have one. I mean, I love being, I think it's, I mean, obviously I think you already know, I like the content. I love my patients. I love the work I do. I love the reading. At nighttime, I read. In the morning, I read with a cup of coffee. I'm constantly reading, and I love that. I also like being my own business owner. That's really fulfilling. I like having my own schedule. I don't have to ask anyone. I need to take that afternoon off because my son has a game, a basketball game. It's like I'm the only person that has, so I like that. So that goes a long way. Things I don't like about what, again, I'm speaking as a business owner.
Yeah.
People have a hard time understanding that doctors are business owners.
Yeah.
That's really hard for folks to understand. A lot of people, I guess I'll say this, a lot of folks think that doctors do things, and doctors do things out of the kindness of their heart, but it's a two-way relationship. So
yeah.
I take care of you, but I can only take care of you if you take care of me. So, right. So, you know, billing, money, those are conversations that are hard to have. People don't like a doctor who is, so sometimes I have a biller who helps me with that, but it's part of the therapeutic relationship.
Yeah.
And for 4 sessions, your bill becomes, what's that about? Is that a defense mechanism? Are you angry? Are you stressed? Right? So I think that's the difficult part that no one teaches you in med school, is how to be, or even in therapy, like patients,
and that's always a touchy subject, of course.
Patients don't like thinking of their doctor as a business owner, and that when we do extra things and when we go out of our way to do something, that's our time, and it needs to be for.
Absolutely.
That's a hard thing for people to do, and so that's been a learning curve for me. And I think it's a therapist who takes cash pay. How do you have these sorts of conversations where you're seen as the person to be doing the caretaking? And it is, I want to take care of you. You don't have to take care of me emotionally at all.
Yeah.
And I can only do this if I have the finances to do it, right?
Absolutely. Yeah. Unfortunately, you can't work for free.
But people expect you to. As a doctor, people expect you to just go out of your way to do things.
Yeah. It's definitely, I imagine that's a difficult part of like the client patient doctor relationship, is just, you know, like, I'm not your only patient, they're not your, like, all those things too.
It's hard. People feel like they are being so loved and taken care of, and that they don't have to take care of me emotionally or any way. Money does have to be talked about, and that's hard.
Yeah, absolutely. And then how do you kind of like avoid burnout? Do you feel like that's been a lot easier since you moved to a private practice?
That's the main reason.
Yeah.
Well, how many patients I see, when I see them, how often I see them, how long I see them. You know, I want to tell you something. A big part of burnout is not necessarily how many patients. It's stress of not being able to do what you think needs to be done. Like that's what was burning me out. Like minutes to help this child who's suicidal, and the child would leave, and then I go home and I'm like thinking about
more time.
That was not that I needed to spend at least 40 minutes with this kid, really making sure they were safe, and maybe, you know, how much alcohol are they using, or right. And so that's the stuff that created burnout for me, was not necessarily my patients at all. It was just the system.
Yeah, like not really being able to do what you were trained to do. Yeah.
And not giving good care. It literally was eating me up. Like I couldn't do it. Like I can't live like this. So.
Yeah, right. I mean, yeah, and then it just like you have to confront your own like morality and ethics, and you know, for I think a lot of people that would feel unethical and thus not fulfilling.
So again, it's not my patients that stress me out at all.
Yeah. Yeah. It's the system.
I see the same amount of patients. I just spread it out and I do it how often I want. And I do like on a Saturday if I have time, or on a Sunday, because Friday I couldn't because I had my son or whatever.
Yeah.
Anyhow.
Yeah. And it's important. I think I've talked to another clinician who's kind of like, yeah, it's really nice to kind of have that opportunity to make your own schedule, because if I'm having a bad day, I shouldn't be helping patients. Like, I'm going to I'm going to approach this very differently than if I feel well rested, mentally capable, all that kind of stuff.
Yeah, for sure. I also play a lot of sports. I do yoga every single day. Every morning I do yoga.
Yeah.
I play tennis, and I love to eat. I love to cook. That help me enjoy my life.
Absolutely. Let's see. Where was I going? So kind of going back to the medication. So a couple students kind of asked, one, what are your thoughts on like antidepressants? And oh, that was meditation. Okay, so that was the medication question. What are your thoughts on antidepressants? Yeah.
Antidepressants, I think, work on one hypothesis of the brain, which is called the monoamine hypothesis.
Mm-hmm.
It is a limited framework. It works about a third of my patients. They do excellent on antidepressant, anti-anxiety. They're both.
Yeah.
But the brain is much more complicated than that. And I think in the last 5 years, psychiatry is going in a very different direction in terms of looking at other systems in the brain that might go awry in depression. But I will tell you, antidepressants have been really life-changing.
Yeah.
Problems. So people give them a lot of pushback, but they've been really helpful. I mean,
I think the other thing too is like another kind of example I like to give my students is like, you know, in physics or whatever science you're talking about, if I have a 4x4 block at a 45-degree angle, that block is always going down at the same velocity, like if it's those dimensions with that angle. For people, you have different physiology. So what works on someone is, there's no one size fits all approach. There's no rules or laws. So currently, so it does make it more difficult to say like, well, yes, this worked on another patient that had these symptom clusters, but there's more, you know, at play for each person.
Definitely. I was saying, I think it'd be really good to get like a thumbprint or some kind of fingerprint on people, right? To know what chemicals are going well, what are not doing so well, what does their brain look like? You know, can this be enhanced with meds or something else, or, you know?
Absolutely. Let's see. I think I'm nearing the end of this, but what are the most kind of common diagnoses that you see come in? Which ones are most difficult to treat?
I would say anxiety, and anxiety OCD, anxiety ADHD, anxiety bipolar. People are just anxious.
Yeah, absolutely.
So, you know, I see everything.
Yeah.
In my private practice, I don't see as many psychotic disorders.
Mm-hmm.
I see less of that. I see more ADHD, substance use, bipolar, and a lot of PTSD and spectrum, autism spectrum. You have adults with autism spectrum, kids on the spectrum. So it just depends. I would say anxiety is the biggest one.
Yeah, I can only imagine. Do you feel, so I kind of also wanted to briefly talk about like how things have changed with COVID and how you're kind of facing these challenges in something that really is a kind of intimate relationship and sessions, and then to try to move it to online. What does that kind of look like? Have there been more issues coming, or?
Less than I would think. I mean, you're right. I think I also see quite a bit of folks who are very resistant, like to come in, and they have a lot of mistrust.
Yeah.
Doctor via telemedicine isn't like the greatest way to start a relationship, but because I see a lot of young people are used to this kind of communication.
Yeah, that's true.
Young guys use House Party and Google Duo and FaceTime and Snapchat and, Instagram. And so I don't think I think it's harder for older folks.
Yeah, that makes sense.
But the younger folks, not so much. It's very hard with little kids, like the 3-4-year-olds.
Yeah.
To do this.
I can't imagine.
That's been different. And also it's very hard for people to do therapy. A lot of people don't have space in the house to say, couples want to be in the same room, but who's looking after the kids, and the kids are in the next room, or we're going to talk about our sex life and when the kids are there. So then a lot of people have been doing these sessions in their cars. So they go in the garage. That's where the parents see me, or the teenager sees me, just to have some privacy. Because a lot of people don't have so I think that's been a major issue, is the privacy issue.
Absolutely. That definitely makes sense. Something that came up in another interview, and I don't know if you work with anyone in this kind of population, but those who are in the kind of like domestic violence relationships, and like who did go in to see a therapist but didn't tell their significant other because it was dangerous. Like, have you seen any of those issues? And like, I feel like it's terrifying. No,
I haven't. No.
Good. Yeah, it was definitely, that's something that I started thinking about. Like, yeah, how would that work? Like,
right. And I see a lot of teens, and they talk about, sex and drugs and cutting and things they don't necessarily want their siblings or their parents to even get a glimpse that they're talking about. Yeah, I popped this, or I did that, or I snuck out last night at like 2 a.m. It's like, so they don't want to talk to me about that. That's hard.
Yeah, I would definitely imagine that. And like, I don't know, I'm not a parent, but I imagine that if my kid was in a therapy session at home, I might be tempted to listen.
And so that has come up.
Yeah.
Overheard, and come into the room, or they call me later and they're like, Dr. Court, we heard her say that, and we heard you say that. And it's like, and they only hear a snippet, right? They don't hear the whole thing. And so they take it out of context. And so what do I do at that moment? In order for me to give them context, I have to talk about what we talked. I don't want to do that.
Yeah.
Because now we've got a major issue that we've got to manage, but I also have to protect confidentiality. And
absolutely, yeah, that would be a very difficult thing to juggle. I imagine. Well, awesome. Is there anything else, any like advice or just anything else you'd like to tell students? It's okay if not.
I think it's important to do what you love.
Mm-hmm.
People went into medical school without any science background. I think that it's important to think of money.
Yeah.
I think it's okay to think of money. Nobody wants to talk about it, but it is okay to think of money. It is okay to think of lifestyle.
Yeah.
To guide your decisions.
Absolutely.
I think those are the main things.
Awesome. And sorry, I did actually have one more question, just because I totally forgot to address this, but what advice would you give those afraid to seek treatment?
That you are safe, that it is totally confidential, that there are some boundaries of confidentiality, obviously, but they're pretty.
Yeah.
There's a lot of leeway
mm-hmm.
in terms of what people can say, and that they're totally in control of the process.
Yeah.
You know, they're in control of it, and that we're not here to be judged, and they're not here to, no one's going to judge them for things, you know, and that's what they're here for, is to get help. Yeah, I think people feel in control of the process and feel like they're not, that they're safe and that it's confidential, and
yeah. I know with like a lot of my friends that their biggest concern in seeking treatment is having to change their lifestyle or having to be on medication. Like, okay, if I go in, they're going to tell me I can't drink anymore. And I think that that's not one, you don't tell people what they can and can't do. Correct.
so I think people can ask me, hey, is this not, you know, I think it's like a process. Like people can decide. That's what I mean by being in control.
Yeah.
Making the decisions. All I can do is say, like, hey, in my experience, is what's been really helpful for people.
Yeah.
People drink, you know, 8 drinks at night. They don't sleep as well than when they drink less. I don't know. Like maybe that would be something to try.
Yeah.
No, you know, I want people just to feel like we're here, we're like in a discovery process.
Yeah.
What works for you, right?
Exactly. It's not telling someone what they can and can't do. There's no judgment. It's working with you to meet their goals.
Yeah. And also, like, it doesn't help if the person doesn't think they have a drinking problem. What's the good use of me saying stop drinking? I mean, they
Yeah.
recognize that, hey, do you feel like this might be a problem? Like, do you feel like it's something you, I don't know, you know, but if they don't think it's a problem, then why are we, you know, we can only go so far with that. So I think it's a process of self-discovery, like slowly peeling back and figuring out what they think is going on, non-judgmental, to maybe reflect back, you know, and it's not just reflecting back what's wrong, it's also pointing out, because a lot of people don't realize how wonderful they are, how
Yeah.
they have, like they're really smart or really creative or really like adept socially. They don't recognize that, and they can use that, and so sometimes they need somebody who has nothing invested by telling them that,
Yeah.
to be able to be like, yeah, you know, you have all these qualities, and I'm wondering if we can use that to help yourself. Or
Absolutely. That's so cool. Well, thank you so much. I know students are really going to appreciate this.
okay.
And I definitely appreciate it given everything going on.
Yeah, no, yeah, of course. Thank you so much for having me and listening to me, and I hope I was helpful.
Absolutely. Well, great. Thank you again.
Okay.